We started implanting these devices about 10 years ago, and we had a very high threshold to implant. So originally we were only looking at patients who had blocked vessels, so they couldn't have a lead in the heart, or they'd had prior infections from their devices. The patients now that are most suitable are really any patient that doesn't require a lead in their heart. So particularly patients who don't require any pacing for bradycardia, or are having recurrent monomorphic ventricular tachycardia, which requires anti-tachycardia pacing. Well, there are only two main contraindications. One is if a patient has a unipolar pacemaker, so the device may misinterpret a pacing spike as a QRS complex and cause inappropriate therapy, or they're having recurrent monomorphic VT, which is responsive to ATP. Those are really the two contraindications. What we do first of all is look at the ECG. There are a couple of markers on the ECG which could indicate there will be an issue, such as a very large R wave, or a very prominent T wave, or a right bundle branch block pattern can be an issue. But we have an automated screening tool now, which is used, produced by the manufacturers, where we screen the patient and it actually looks at an electronic template looking at the QRS and the T wave. And if the patient passes on that template, that gives us a good indication that they will be able to pass screening with the device implanted. The other issue is that there are 3 vectors you can use. Ideally, we like to see 2 vectors that pass to give us some reserve, but it is perfectly acceptable to have 1 vector for the patient. So we're very careful with our screening, because particularly in my population of patients, they're young patients who have hypertrophic cardiomyopathy. So we make sure that we have at least 2 vectors that are suitable, and if we're not happy on the left side of the sternum, we'll screen on the mid-sternum or the right side to get the best position for the device for sensing. And also, after we've implanted the device, we know very well that you need to exercise the patient so they don't get double counting of their T wave and inappropriate shocks. And we've seen that in the registries from our HOCM population, looking at their outcomes. Generally speaking, it's becoming increasingly evident now that originally we started with younger patients for implantation, but older patients are at risk of infection and also have renal impairment and diabetes. And again, those patients have a higher incidence of device infections, and they're living a lot longer than they used to. So now we're starting to consider older patients in their 60s and 70s for subcutaneous ICD if they don't require a transvenous lead. Because we know from large-scale registries such as NCDR, these patients are more at risk of lead and infection complications going forward.